Thanks. So I am a lab director at EGL Genetics, a laboratory that does fee-for-service testing. And what we're going to be talking about is some of the data that you don't get from these large sequencing studies, and how going after deletions and duplications can really help complete that clinical picture for a patient that might not get the answer from just a whole lot of sequencing. So I don't have to tell this group the benefits of exome sequencing, the patients that have been diagnosed, the genes that have been discovered. We hear that over and over again. But we have to keep in mind that there's also deletion and duplication analysis. And these analyses are complementary to the data generated by large-scale sequencing studies. And when designed over a large scale, over a genomic scale, they can be agnostic to clinical features. So you don't have to have a specific clinical suspicion, a single gene. You can look across the entire exome to complete that clinical picture. At EGL Genetics, we have used gene-targeted arrays and panels for a long time. These are custom-designed arrays that complement and match our gene sequencing panels. We are able to get multiple panels per array into a single design, and this allows efficiency in batching samples and allows us to meet clinical turnaround times. The number of probes per exon is proportional to exon size. The resolution that we're going for is single exon deletions and duplications. We have picked up smaller things in smaller exons, working with a 60 mer probe. The smallest exons, of course, are going to be smaller than the probe itself, but we are able to customize that targeting to the size of the exon that we're trying to detect. And then we can also take that targeting out into the flanking intron and exon boundaries. And it's important to remember that CNV analysis by array aCGH is a standalone assay. We don't have to go back and confirm with a secondary assay when we have an abnormal finding. So the first case I'm going to tell you about is a case where we were able to complete this clinical picture using deletion duplication analysis. This was a 12-year-old male. His clinical features included myopathy, hypotonia, muscle pain, a gait impairment, a slight leg length discrepancy, and headaches. He'd had an array of, no pun intended, he had a number of previous tests, including a muscle biopsy, a SNP array, a congenital myopathy gene sequencing panel, and CK levels. The family history was non-contributory. And we performed exome sequencing after he'd had this initial gene panel sequencing done. And we found one variant that was of interest in the MuSK gene. MuSK is the gene for an autosomal recessive congenital myasthenic syndrome. And this particular variant had been reported in the literature in 2 different families, but there really wasn't enough evidence in those papers to say that it was causative of disease. And what made us pull back a little bit on that classification as well, that it was present in the population. This is the minor low frequency from the exact data, a higher frequency than we would expect for a recessive disorder. And when we contacted the healthcare provider and said, how about a congenital myasthenic syndrome? They said, well, maybe, but it's not great. And we said, okay. And we also did not have a second change in this gene for a recessive disorder. There's 15 exons, we had over 20x coverage, and this really, at this point, we felt was a variant of unknown significance. Because of the muscle phenotype, they went on and ordered a neuromuscular deletion duplication panel, and lo and behold, we found a deletion of exon 6 in the MuSK gene. So at this point, the provider went back to the case and said, let's look at a congenital myasthenic syndrome for this person. And note that this is, let me orient you here. These are, each little dot is a probe. Along the blue line is normal. The ones shifted down are a loss. And this little small teal rectangle there is exon 6. So you can see that there are probes clustered within exon 6. In this loss, and we are targeted more densely within that exon, but also across the gene, and we're able to pick up this very small deletion targeting this way. We were able to do family studies for the sequence variant. The dad has it, the mom does not, and we're still hoping to get the deletion testing. I'm sorry, the dad had, The mom does not. We're hoping to get the deletion testing done on the mom, but there's pretty good reason to believe at this point that they are likely to be in trans. And the physician was still going to go back and reassess for this particular clinical diagnosis that they had not previously considered. But there's a pretty good chance that we've closed the loop on this one. Because we can look at a large number of genes across the genome, the approach can be rather agnostic and still pick up small events within genes. And the next case I'm going to tell you about was a rather unexpected diagnosis. The second case is a 2-month-old male. Clinical features included dolichocephaly, dysmorphic facial features, sparse hair, cholestasis, hypotonia, and an abnormal MRI. They'd had quite a bit of biochemical testing done already, and we did a cholestasis gene sequencing panel, which was normal. I'd had a karyotype done in skin, looking for mosaicism. And this testing was non-diagnostic. We went on and did an exome. We found 2 variants of unknown significance that had in genes that had some overlapping features to what this child had, but even though these genes were well covered, there was no second change in either gene, and it really didn't explain what was going on in this infant. So they went on and did an array, and we found a single exon deletion. Again, the little square down here is an exon. This is exon 6 of the NSD1 gene. This child has Sotos syndrome, and at the age the child presented, there weren't enough features to make the clinical diagnosis, and this was a bit of a surprise to the clinician who saw the baby back, now 9 months old, and did fit the clinical features and had enough features to express the syndrome, and we had a definitive answer for this case. The next case I'm going to tell you about is a case of expanding the mutation spectrum. When you go after genes one at a time individually, you have to be really sure, if you're going to do an MLPA, a qPCR, that you really need to get deletion duplication data for that gene. We have the luxury here with gene-targeted arrays of being able to target a lot at once. And this is a 14-year-old female. She had experienced a retinal detachment, pigmentary retinal changes, and specifically had a clinical suspicion of either Stickler or Wagner syndrome. We did a comprehensive eye disorder sequencing panel that at the time consisted of 141 genes. And the results were 3 variants of unknown significance in 2 genes, and neither one really fit the clinical picture. So this was considered non-diagnostic at this point. But they went on and did the correlating deletion duplication panel, and we found a single exon deletion again. And I'm specifically showing you single exon deletions, duplication events, because you really can detect small events with targeting this way. In this case, there's a deletion of exon 8, and this is of particular interest in this gene because it's the first single exon deletion that was described in the VCAN gene. VCAN is the gene for Wagner syndrome, which was the specific clinical suspicion coming in. And it's even more interesting because typically most cases of Wagner syndrome due to VCAN are caused by splice variants that give rise to loss of either exons 7 or 8. And this was a deletion of exon 8 that had not been previously described. So we thought that was just cool. For cytogenetic arrays, we have begun to use the V3 arrays. This is a 60K array with a cytogenomic backbone and enhanced exon level coverage of genes associated with developmental disorders. And this type of testing is considered first-tier testing for individuals that present with non-specific features, such as multiple congenital abnormalities, dysmorphic features, developmental delay, and there's a fairly high positive rate with cytogenetic arrays. And in this case, we had a 7-week-old female with dysmorphic features, cardiac abnormality, and so the next step was the cytogenomic array. Which we did, and found a 5-probe deletion in the HDAC8 gene. This gene is X-linked. This is a female, so you see the shift. You see the shift down here is a heterozygous loss. The deletion includes all of exon 3 and part of exon 4. Loss of function variants in this gene cause Cornelia de Lange-like syndrome, and partial gene deletions of HD-AC8 have been reported. So this was quite consistent, but this is a very small deletion, and it's only a 5-probe call. It's about a 1 kb total deletion. And so this is consistent with the diagnosis of Cornelia de Lange syndrome, and the healthcare provider confirmed that this made sense. But we were curious because we haven't been using the V3 very long. We wanted to go back and see what this would have looked like on other array designs. These are both normal arrays. This is not our deletion patient. But in our gene-targeted array, these are relatively small exons. We have a scattering of probes through these exons. This is exon 3, exon 4, which you saw over here. And so on our gene-targeted array, if we were going after HD-AC8, we would have about the same number of probes that the V3 array had. And on V2, a couple of these exons in here are 3 and 4, but there really isn't the probe coverage on the previous design to detect this deletion. And so in doing that first-tier test, they got the answer, which was the HD-AC8. The last array design that I want to mention is our medical research exome array. And this is an array that covers 4,600 medically relevant genes enriched over the general exome content. So in designing an array, you have the real estate and you have the probes to spend. And so you need to decide whether you want a smaller design and more samples per array, or whether you want more for a single sample. And in this case, this is a 1 million probe array with enriched targeting over 128,000 exons. Now, in this design, we're not going to have the same dense exon coverage that we have on a gene-targeted deletion duplication array, where we are saying we will detect exon-level deletions and duplications, but there was still room for the genes that are associated with disease to target 2 to 3 probes per exon, and in some cases more. And this targeting also includes the flanking intron and exon boundaries. And I just want to show you an example here of the performance when we go to a whole exome array. This is the gene-targeted array for DMD. And this is a single exon duplication, exon 30. That's our gene-targeted. And on the exome array, it looks like that. So we still have reasonable coverage for these genes that we really care about, and we're able to cover those 4,600 genes this way. So the benefits of doing this. There are many potential outcomes, as I've shown you. You can find clinically relevant findings. We do detect carrier status from time to time. There are incidental findings, and we will find things in genes that are adult onset, actionable, not actionable, and these are the same benefits and limitations that you have with doing exome sequencing. So this really is a genomic approach. Whether you're sequencing or looking for deletions and duplications, you have to consider the same things, but keeping in mind that having a deletion duplication analysis is a powerful technique with many of the same benefits, and you have to be considering those benefits and the limitations at the same time. I've shown you cases that demonstrates that having that deletion duplication component to a test adds clinical value, and we can cover most of an exome this way, so it's scalable, and that really makes this different than using very reliable assays such as qPCR or MLPA, where you have to target a specific gene. And here you can take that agnostic approach of what should I be concerned about. The time is coming where we will make these CNV calls out of NGS data. Lots of people are trying, and you can make the calls when there are deletions and duplications, but we still need to confirm that calling by other methods. The CNV detection, the ability to detect CNVs from NGS data is going to be based on the coverage, the quality, the sequence context, and some regions are going to be easier than others. There's still a significant false positive rate, and for many of these algorithms, you can pick up something that's real, but you pick up 10 other things as well, and when you have an agnostic case, you have to sort through every one of those calls. And I mean, right now, the array data, we believe, is still more reliable. We have an interesting case of a mosaic PAX6 deletion that we did confirm by another method, and that's at poster 708 if anyone's interested in seeing that. And that's the lab.